Wonderful. Well, thank you very much. It's great to be here. Before I got this invitation, I must have heard implicitly the term biohack, but I never really thought about it. So I've come here with great curiosity to learn, and I've been learning a lot so far. I'm really enjoying it. So hopefully I can contribute something to your knowledge base that might feel relevant to biohacking. They used to call it health, perhaps, but that's where we are. And I suppose in terms of what I do, or rather really what these substances do, psychedelic compounds, is that they're hacking the mind, they're hacking the brain. And I suppose that's where I fit into this picture puzzle. What are psychedelics? Let's start very much with the basics. Well, we can define them by their etymology. Psychedelic means mind revealing. So already that's hinting at a kind of hack. We're getting into something that ordinarily, by implication, isn't fully visible to us, the mind, the psyche, the soul. And with these substances, we make manifest, we reveal aspects of the mind that are ordinarily not visible to us. Another simple way to define them is to give you some examples. I'll give you some examples now of classical, so-called classical psychedelics, and then I'll give you a definition, arguably the most concrete that I could offer, which is pharmacological. It's based on how these drugs actually work at the molecular level in our brain. So examples, we have psilocybin, the prodrug of psilocin occurring in the so-called psilocybe species of mushrooms, grow throughout the world, and they contain this substance, psilocybin, broken down into psilocin in the body once ingested. And it's this that works on the serotonin system, like all of these classical psychedelic compounds. Dimethyltryptamine, something that occurs actually throughout the plant world. It also occurs in some animals. It can be found in our own bodies, albeit in minuscule amounts. It's something that's included in terms of leaf material in an Amazonian tea called ayahuasca, which is a combination of these DMT-containing leaves and also vine that contains monoamine oxidase inhibitors that stop the oral breakdown of the DMT. So it's a way of rendering DMT orally active. It's something that's been used for possibly thousands of years in ceremonial plant medicine context. And now people are experiencing ayahuasca through retreats and such, like traveling to the Amazon or just doing it in a more underground way. LSD, arguably the prototypical psychedelic, prototypical because it was only after LSD was discovered, famously by Albert Hofmann in 1943, that we had this major wave of scientific interest in these compounds in the West. And it really spawned the first major wave of modern scientific interest. Now, these classical psychedelics, as I've already alluded to, all work by mimicking and hijacking, as drugs generally tend to do, an aspect of the natural system, our bodies, and a particular organ in our bodies, our brains, and they hijack a particular aspect of the serotonin system. First of all, just looking at the molecular structure, we can see how psilocin, DMT, and also LSD do look quite similar to this naturally occurring brain chemical, serotonin, important for such a range of different mind and brain functions. So then following this, we ask that key question, what aspect of the serotonin system do these compounds hijack? Well, we now know with quite a high degree of confidence that it's a specific aspect. The serotonin system is one of the most complex neurotransmitter, neuromodulatory systems in our brains. It has a range, some 14 different receptors, which are kind of like the locks that the keys being either drugs or serotonin itself, come in and they'll turn these locks in a particular way, and that will lead to a cascade of different effects. And all these different receptors can do quite different things. Sometimes their functions sort of oppose each other. And we know that there's a particular serotonin receptor subtype that is critical to how these compounds work in the brain. It's the so-called serotonin 2A receptor, We know that because from a range of different studies, if we give what we call an antagonist or a blocker that comes in and it'll selectively block this particular receptor, then people essentially won't trip. They won't have a psychedelic experience. We also know that the affinity of a psychedelic compound for this particular receptor correlates very strongly with its potency. So, for example, LSD, very high affinity, and you only need tiny amounts because it's so potent. So these compounds come in, and like serotonin, they'll stimulate the receptor. They're agonists. They'll provoke a response. And what follows from that response? Well, we know at a relatively low level that these compounds promote plasticity in terms of growth of new functional units or functional components of neurons that can facilitate communication. We can take it up to a higher level and look at things like behavioral change, behavioral plasticity and flexibility, cognitive plasticity. We can take it up to an abstract level and think of things like psychedelics promoting imagination, abstract thinking, divergent thinking, a component of creative thinking. So there's a kind of generalized enhancing effect on plasticity. When we break that down, what is plasticity essentially? It's the capacity for change. So that's a key function that seems to be mediated by the serotonin 2A receptor. Now, I just want to breeze through this slide because it's easy to get stuck in it, but the reason why I present it is to contextualize how psychedelics fit in terms of the history and the developments in psychiatry. So a major event, a series of events happening in the 1950s during the so-called pharmacological revolution included such things as the discovery of the first antidepressants, the monoamine oxidase inhibitors. Remember, that's actually a component of the ayahuasca brew as well. And that has a generalized effect on brain chemicals, increasing serotonin, but also noradrenaline and dopamine, these sort of pro-energy, energizing monoamines. And then we have a major development happening in the mid-1980s with Prozac and related drugs being discovered. And now we have these compounds that are a bit more selective in their pharmacology. They're increasing not just monoamines in general, but a particular one, serotonin. And it's really with this that psychopharmacology starts to believe with a bit more confidence that serotonin seems to be important in the modulation of mood. And now, in a way, we're going full circle because psychedelics have been used as healing compounds, holistic healing compounds in plant medicine contexts for hundreds, perhaps thousands of years. And it's intriguing to reflect on the fact that their pharmacology is more selective than that of the SSRIs. So we could consider this in a kind of paradoxical way as progress in terms of the precision of the chemical pharmacology, as well as going kind of full circle in sort of going back to go forwards, rediscovering an ancient therapeutic approach. Now, also the history of psychiatry in terms of psychotherapy and more specifically psychoanalysis, Freud, for example, dominating psychiatry for the first half of the 20th century, and then the so-called pharmacological revolution that comes in the 50s with drugs starting to take over. And now we have this interesting synergy, which isn't either just a drug or a psychotherapy on its own, but rather a drug that changes the mind, the landscape of the mind in a particular way that might facilitate a certain kind of psychotherapy that can utilize that. These developments are also helping us understand serotonin itself, which has been a mystery for so long in terms of what it does in the brain, what it does to the mind. People have offered hypotheses such as that serotonin is important for moderating stress. And this ties in with how people think of what SSRIs do, that they can, in a way, sort of facilitate resilience, stop the bottom from falling out, aid management of severe crises, for example, psychological crises, and can moderate and mitigate negative affect. Some would wager also affect in general, or intense emotion. The edge can be taken off with these chemicals. Serotonin also aiding patients, increasing evidence for that, and now really intriguing evidence that puts a slightly different, more complex spin on what serotonin does in the brain and in the mind, which suggests that it increases our sensitivity to context. So if you up serotonin levels with pharmacological interventions, for example, that will accentuate the influence of environmental factors. If those factors are adverse, if the conditions are adverse, then people will do badly with an increase in serotonin levels. If they're favorable, if you have support, then you may well do well. And this ties in now to how we're thinking of a more specific aspect of the serotonin system, the one that psychedelics work on, and what that does, what that key function is about. I've already alluded to plasticity, and that ties in here. We've moved on from thinking that these are compounds that are simply psychotomimetic, that they can mimic aspects of psychosis. Certainly they can. And they can also be therapeutic agents, but even that rule is more nuanced than that. And it's more that via stimulating this particular receptor, you can open a window of plasticity, open a window of sensitivity to context, environmental context, but also inner context, what's in the agent to begin with in terms of expectations, experiences, memories, trauma, for example, and making one more supple and sensitive to these contextual factors. And so if we think of serotonin in that way, mediating sensitivity to the environment, I think we could think more accurately about the aspect of serotonin that's mediating that and put our focus onto this particular serotonin receptor subtype. So that provides a kind of low-level chemical context for psychedelic therapy, if you want. And as things go on, I'll move up the levels to more network level and a psychological and experiential description of what this treatment seems to do. But before I do that, I just want to summarize the evidence base for psychedelic therapy. We can begin with the safety profile, that we know these compounds have a very low addiction potentials. Animals won't self-administer these compounds as they might other drugs of potential misuse, alcohol and such like. In a way, these compounds are quite aversive, both to animals and to humans. Humans can sometimes have, really hellish experiences under these compounds, and yet afterwards, paradoxically, they'll say they feel renewed, refreshed, sometimes reborn. And so that's kind of useful in terms of the abuse potential of this potential medicine, in that these aren't compounds that are Moorish in the classical sense that many drugs of potential misuse are. They also have a low toxicity profile, psilocybin especially, much lower than other new interventions being used in psychiatry and in the management of depression, like ketamine, for example. So it really has a favorable safety profile in that respect. And then meta-analyses have looked at the old specters that have hung around these compounds, things like induced psychoses, enduring perceptual changes, and found that the prevalence of these cases are extremely low. They can happen, but the ratio of benefit to harm seems to be much more weighted on the arm of potential benefit. Now, if we focus on the potential benefit, what's really exciting about this treatment modality is that the therapeutic effects appear very quickly. So we've seen drops in our depression scores just a day after the intervention, and this is in people who've had their depressions for, on average, over 15 years. They've tried some of them 11 different antidepressant medications without that affecting their depression in a significant way. Also different psychotherapies, close to 90% of the sample had tried at least some form of psychotherapy, often multiple therapies, and that hadn't budged their depression either. So we see these rapid changes, and we also see them enduring. The maximal effect size was actually at 5 weeks after this isolated 4 to 5 hour experience. So that's really quite paradigm shifting in the context of a pharmacological, what you might interpret as a pharmacological intervention in mental health. That rather than being on a drug, consecutively, chronically medicated, it's that you have a particular kind of experience, a profound experience that then seems to endure. So that's been demonstrated quite nicely by the likes of Roland Griffiths and his team at Johns Hopkins, where they've given quite a high dose of psilocybin to people who'd never taken a psychedelic drug before, and they found these enduring increases in psychological well-being that remained significantly increased over a year on from that single time-limited experience of just 4, 5, 6 hours under the psilocybin. They also found that people would rate their experience as being among the most profound of the whole of their lives. They would put it up there with things like the birth of their first child. And that sense of meaningfulness of the experience is something that also endured as well. Some people would describe their experience as being mystical. You might think of a synonym for that, a more secular synonym, as a peak experience. Whatever your favored perspective on this, what seems to be compelling is that the experience is very profound and is felt as meaningful. So population studies have looked at different mental health outcomes. Peter Hendricks in Alabama has looked at suicidality in a large cross-section of the US population, some close to 200,000 people, looking at different factors and then looking at their relationship to mental health outcomes. He looked at psychological distress, and he also looked at suicidality, and he found that use of psychedelics was an anomaly among use of drugs of potential misuse. So the general rule is the more you take of a drug, the worse your mental health, whether it's alcohol, whether it's heroin. That rule stands up, but not with psychedelics. So those who reported psychedelic use, I think within the last year, actually had significantly lower rates of suicidality and psychological distress when controlling for other potentially confounding variables. Now, the modern wave of controlled clinical research with psychedelics was really kicked off in 2006 with a modest study looking at psilocybin, a single treatment session with psilocybin for obsessive-compulsive disorder, finding promising outcomes there, but those researchers being really a lot of pressure put on them by stigma and regulation, and their work wasn't really allowed to continue and flourish. But the signs were promising, and this has since been followed by more recent work looking at psilocybin for end-of-life distress, so people given terminal diagnoses, experiencing existential anxiety and depression in relation to that, and then being given psilocybin with psychological support on either just 1 or 2 occasions, and then these consistent findings of rapid and enduring improvements in these mental health outcomes. And crucially, again, these responses appearing to be significantly mediated by the kind of experiences that people were having under the psilocybin. Others have looked at addiction, smoking addiction, 80% abstinence rates after 2 treatment sessions with psilocybin at 12 months on. So really remarkable outcomes in the context of leading treatments. Others looking at psilocybin for alcohol dependence, again, very promising and exciting drops in drinking behaviors with psilocybin therapy for alcohol dependence. We've looked at depression. I've already described some of those results. Treatment-resistant depression. Others have looked at ayahuasca for severe depression. We're now looking at psilocybin versus a leading SSRI in the context of major depressive disorder. So people will either get 6 weeks of escitalopram, very selective serotonin reuptake inhibitor, one of the leading SSRIs, and people will either get that or they get 2 full-dose treatment sessions with psilocybin. So we're really now trying to put our our resources where our mouth is, and put this to the test, because we do believe there is major potential here, as do others, as do investors. Some private money coming in now, several millions of dollars for a multi-site trial, potentially pivotal registration trial in Europe, covering at least 13 different countries. Similar work being planned for North America. So things are really starting to happen now. And how, importantly, does this work? Here I would refer us to arguably the leading model of how the mind and brain works more generally outside of the context of psychedelics. Just what's dominating cognitive neuroscience at the moment, what's dominating psychology and psychiatry more generally as well. And it's this predictive processing model. It's a model of the mind that says that much of what the mind and the brain does is to impose internal models on our experience of the sensorium. And really that our experience of the world is very much dominated by these internal models. They might, to some extent, be innate, and to a large extent, they're also learnt. And perhaps in certain psychopathologies, they can be overlearnt and become over-dominant. We can think of biases in depression, for example, a pessimistic bias, a negative cognitive bias, how this can become kind of entrenched and then dominate the way we think and really the way we feel as well. Other examples, phobia, where we might know our beliefs, our internal models, which are beliefs, their predictions, their assumptions, their expectations. We might know that they're entirely irrational, and yet we're compelled by them because of the dominance of these internal models. Similarly, eating disorders, which was talked about earlier in the context of fasting, for example. But when this happens, it's so clearly pathological that people look in the mirror, they think they're fat and they're not at all. Yet these irrational beliefs become stamped in for whatever reason. I'll suggest a reason in a moment, but I'll also suggest right now a potential solution to aberrant beliefs, which quite simply would be to relax those beliefs, let's say in a time-limited plastic state, and then work on their revision. And that's what I would submit is what psychedelic therapy does essentially. So we know predictive processing rules supreme. We just need to look at things like optical illusions or the way we can fill in this kind of garbled text and read it relatively coherently, even though at the granular level, the units, the letters are jumbled up. We can still see the gestalt, and we can make sense by grouping by our internal models of what this text is saying. So predictive processing has been described as a kind of handshake between internal models or beliefs and data, which might include things like what comes in from our sensorium through our different senses, our eyes, our ears, our touch, but also feeling states, what's coming up in terms of bodily sensations within us. And so this kind of handshake, as I've already suggested, is overweighted, it's biased to the side of beliefs. That's what happens ordinarily. This cognitive aspect of modern humans is arguably more dominant now than ever, and perhaps we're starting to realize this and thinking that we should think more carefully about harmonizing with our sensations and with data. But that top-down, top-heavy aspect of our minds, I would submit, is a large part of psychopathology, of mental illness. It might arise because of conditions of uncertainty that are very difficult for us to tolerate. When might that be especially extreme? Well, perhaps in the context of trauma, for example. So I just offer this sort of loose kind of throwaway model. Let's see if it's of any use as we go forward, but I call it TIBER. I could go into why, but I won't. But it's an acronym that stands for Tightened Beliefs in Response to Uncertainty. And we can use uncertainty and trauma as kind of interchangeable there. And perhaps a solution and perhaps a desired end state we might want to get to is a situation where the mind and the brain isn't so top-heavy, but there is a more harmonious handshake between internal models and our experiences of the world. And so this is how I propose we get there with psychedelics, and I call this one the rebus model, relaxed beliefs. So not tightened, like in pathology, but relaxed beliefs under psychedelics. I know it's a bit of a fudge, the acronym, but it sort of works for me. I think it might be memorable as well. And so it all starts with stimulating this particular aspect of the serotonin system, the 2A receptor, initiating this window of plasticity. I call it an entropic hot state, a state in which things get kind of jumbled up. There's more uncertainty and at least for a period. And like I said, it's often not pleasant, the acute psychedelic experience. But in this state, we can have a relaxation of beliefs at multiple levels, including at the highest levels, particularly with high doses, where people will experience a breakdown of internal models as high as our own sense of self, and people have a profound realization that they have constructed their self, their identity, as an internal model, and it's not something that's absolute as they perhaps assumed before they had this experience. And then out of this kind of flattening of the mind's landscape, an opening of the mind's landscape, people often report spontaneous insight, and it's this insight that seems to mediate to a large extent the revision and the recalibration of people's beliefs so that they can be more in tune and more harmonious with what I call data experience in the world. That all sounds a bit abstract. It's a model, and all models are wrong. So let's see how wrong it is and whether we can improve it going forward. But I provide it as a sort of heuristic. I think it's useful, and in time we can test it, we can scrutinize it, and see whether it helps us or not. But if we just listen to our patients, what are they telling us, and how can that inform how we understand this treatment might be working? They often use analogies that are quite mechanistic. They'll talk about their minds and their brains feeling as if they've been rebooted, reset. Here's a patient from our depression trial saying, it was like when you defrag the hard drive on your computer, referring to their mind and their brain. Now, if we look at what happens to the brain under a psychedelic acutely, so this is within the experience itself, we see a couple of principal things. We see, if we look at large-scale brain networks observing different distinct functions, whether they're vision or hearing or movement, motor action, or higher level things like thinking, cognition, or even introspection, arguably that highest level function for humans that's so especially advanced in our species. And there is a particular network that's quite closely associated with introspective function. It's called the default mode network. It's exciting a lot of interest in cognitive neuroscience at the moment, especially over the last 15 years or so since its discovery. And what we find is that when this network breaks down under psychedelics, and as a rule, networks do appear to break down under psychedelics, but when this network breaks down, people will describe some of the more profound aspects of their experience. They'll refer to a sense of ego dissolution, and we see a strong correlation there between ratings of ego dissolution and the breakdown of this particular network or system, which is arguably the leading candidate as a sort of functional dynamic system that can correlate with our sense of self and self functions. So there's a principle that these networks break down. There's a disintegration, if you want, within large-scale brain networks under psychedelics. But brain networks also appear to lose the extent of their separateness. And so, in a sense, their specialization, their difference, their level of distinction, segregation from each other. And so this desegregation of brain networks is something that we've seen quite reliably, and other teams have now. Here we're looking at the visual system. That's the blue blob at the back of the brain, the primary visual cortex and a particular aspect of it that does very low-level visual processing. We're asking the question with this analysis, where in the brain is activity correlated to that blue region? We find that ordinarily activity is quite constrained and restricted to the visual system. So a part of the visual system is just talking to other parts of the visual system. There's high specialization there. Under LSD, and as we've seen with other psychedelics, that rule breaks down and much more of the brain now starts to kind of bleed in to visual function, influencing visual function. That's something that we've depicted in a number of different ways. People tend to quite like this image, which shows different communities of regions. So the colors are communities of regions, which are the small blobs. And then the lines between them are communication patterns that are above a certain threshold for significance. And we can see ordinarily most communication goes on in a kind of cliquish way within certain communities, certain systems of function. And yet under psychedelics, there's a much more open conversation going on between different systems in the brain. So that's what we see acutely, but what do we see post-acutely after people have had their profound, potentially mystical type experiences, peak experiences under these compounds? What happens when they come down? Well, when we look the next day, and it should be said that I think we're just scratching the surface here. This is really just the first bit of data that we have on this. It's from our depression trial. It's just 1 day post-treatment, but we want to ask, given these enduring effects, what happens weeks, months after this treatment? But this is all we have at the moment. We looked the next day, and we found something quite different to what we see acutely. So instead of networks breaking down, we see that they reintegrate. We make that assumption, knowing that they break down acutely, that they're reintegrated post-acutely with actually a slight expansion in the spatial extent of the network, at least in the context of the default mode network. What that means in terms of the big picture, we don't know, but in terms of we have some ideas, but in terms of the therapeutic meaning of it, well, it does seem to relate to therapeutic response. So those patients who responded to the intervention and had significant drops in their depressions that rendered them classifiable as responders at 5 weeks at a key endpoint when the effects were maximal, were those who showed this reintegration to the largest extent. So it seems to be useful. It seems to be important in mediating the therapeutic response. So what I've given you in this talk is a kind of very mechanistic account of how psychedelics work in general and therapeutically. But I don't think it entirely does justice to the very rich phenomenology of the psychedelic experience. And one component that I've left out that I just want to address now in the last 5 minutes or so is insight. Remember, we started off by reminding ourselves that psychedelic means mind revealing, making the mind more visible to itself, the mind revealing itself to itself. And what we found in our therapeutic work is that the magnitude of people's ratings of insight acutely is predictive of the therapeutic response in the longer term. I have a patient here, and there's very many examples of similar things and much richer accounts, of course. But here, just the patient saying, I had fresh insight into things. It was as if the scales dropped from my eyes. So this is kind of alluding to the dissolution, I would suggest, of a kind of occluding quality to the mind. And because of that, that breakdown of a kind of blockage and obstruction, that one can experience a broadening of the mind and be more fully aware of things that perhaps previously were kept from consciousness. Why? Perhaps because they were hurtful and difficult to integrate. So that's the therapeutic model. You can see the correlation there, drops in depression scores correlating with insight. Here's just a schematic to refer us to brain dynamics. It's an attractor landscape, an energy landscape. It's a way of depicting a dynamical system with a static image. And we can imagine this ball having dynamics, being able to move around. And in this landscape, it's going to fall into that dip, into that depression, and it might get stuck, like in treatment-resistant depression, and find it difficult to get out. Everything's pulling them back into this rut, into this deep depression. And so what might we need in order to remediate that situation? Well, we could flatten the attractor landscape, flatten the energy landscape. In that way, the ball would be able to move out. It would have freer dynamics. It may well be felt as a freeing up of the mind. And that's an analogy that I just want to leave you with, and also with this theme of reconnection. I talked about a healthy handshake between internal models and the world that can happen with successful treatment. And again, this is something that people will describe with the treatment. And I just want to give you some of these quotes. We've written about this in a more formal way from qualitative work, and then proposing certain experiments we can do to test this more concretely. But let me just read you some of these quotes. This one, and these are from patients in our trial, other trials. Here's the first one. This connection, it's just such a lovely feeling. We are all interconnected. You hear that kind of thing in all sorts of contexts with psychedelics. I was being reminded of things I already knew. I was learning without being taught. There had been, I felt, an opening of the heart. I was convinced in that moment I'd figured it all out. It was right there in front of me, love, the only thing that mattered. Now, this sounds kind of platitudinal, it can sound wishy-washy, but you hear this from people, and it's so compelling for them, and it does seem to be what's mediating their wellness when it works. And I'll just leave you now with this last quote, which comes not from the context of psychedelics, but from an astronaut taking part in the lunar missions, being up there and experiencing the overview effect, looking back at the Earth, seeing it in its totality, and then in having that big picture, being perhaps able to put things in perspective. And I think that's a very useful analogy for thinking about how psychedelic treatments can work. In my cockpit window, every 2 minutes, the Earth, the Moon, the Sun, the whole panorama of the heavens. And suddenly I realized that the molecules in my body, the spacecraft, the body of my partners were all manufactured in some ancient generation of stars. I heard Carl Sagan's quote earlier. It's very much related. I felt an overwhelming sense of oneness, of connectedness, and insight and epiphany. So I'd just like to thank those who've supported this work, the UK Medical Research Council, Shamil Chandaria and his foundation, who are really opening things up for us now in the UK with a new centre at the University of Oxford that will run in parallel with things at Imperial, Alex Mosley Charitable Trust, and to thank you very much for your attention.
Thank you. Thank you very much, Dr. Carhart-Harris, for such an insightful overview. You very well gave an overview of the different positive therapeutic interventions and their implications. Now, there is some concern with the use of some psychedelics, especially on a repeated basis. For example, LSD seems to have high affinity on 5-HT2B, which has been linked to increased risk for valvular heart disease. So you can basically grow tissue in your heart that can be problematic. So there is a lot of discussion on microdosing and if that's safe compared to having high dose experiences that seem to break down the default mode network and all of that. So what is your take on microdosing and the potential risks? Because I know that there are several medications that have been taken off market because of this particular effect.
Yeah. No, sure. We should think about all of these things. LSD has comparatively quite a low affinity, I think, for 2B. It has especially high affinity for 2A, 1A. I don't think LSD has such a high affinity for 2B. Psilocybin might. The thing about LSD, and particularly microdosing, is what's suggested by the name, microdosing. There's such tiny amounts of the chemical, and when the chemical has preferable affinity for 2A, that's where we can think in those very, very low doses the effect is going to happen, and there's probably going to be negligible functional effects at something like the 2B receptor. Those kind of medications that caused issues there include things like fenfluramine that was taken off the market as a dietary suppressant. There's some questions that hang over SSRIs because in general, increasing serotonin levels are going to cause issues in terms of if serotonin's up, serotonin itself is going to hit 2B, it's going to have effects there. And so, let's put this in the context. Prescription rates of SSRIs are going up at record levels. And so if there was really major concern here, how could that happen? Of course, we could think of, market forces and dark forces like that. But that kind of helps put these in the context. Another really important thing to say is that unlike traditional pharmacotherapy, taking drugs, these treatments, and let's push microdosing to the side for the moment, because that's not really our focus. It's something that's happening out there as a kind of meme. I would, caution people, let's see the evidence first, because it's not there yet. There's just a lot of anecdote and this kind of meme that's been created. But our model is to give an isolated experience. And so in that context, if there is significant 2B, it's there in just one shot, and it's very unlikely, I think, to be causing any kind of valvopathy.
Right. So you are pretty much in line with the traditional use, which also promotes more of a ceremonial use, specific moments for specific reasons, rather than just going on with it every day for performance reasons or for mood reasons, etc. So thank you very much, Dr. Carhart-Harris. That was excellent. Big hand.